All right, so welcome everybody. I'm Tobias Carling from the Carling Adrenal Center down here in Tampa. Good to be with you all. First of all, we have had so many patients and patients' families and friends and families from all over the world reach out to us because of these hurricanes that we've had over the last month. And fortunately, the Carling Adrenal Center, the hospital for endocrine surgery, we're all doing great. There certainly are other areas in Florida and North Carolina and other places that were much worse affected than us, but we appreciate your thoughts and prayers. So we got a lot of questions, so thank you so much for sending questions in. And if you have questions, definitely feel free to send them in. And I'm going to start, first of all, to answer two questions that I almost get multiple times a day. Sometimes this question I get asked 10 times a day. So I figured I'll just start with those two. So question number one is, can you save some adrenal tissue when you do the operation, meaning doing a partial adrenalectomy, or another word for it is cortical sparing or function preserving adrenalectomy? That's question number one. Question number two is, will I have to take steroids after the operation? Will I have to take hydrocortisone, meaning supplementing the cortisol after surgery? So first question, can you preserve adrenal tissue, meaning doing a partial adrenalectomy? And yes, the short answer is yes, in almost all cases. There's some exceptions to that rule. For instance, if you have a very big tumor and there's a significant concern of cancer, in that scenario it might be the wrong thing to do to try to preserve adrenal tissue. But for the most part, we do partial adrenalectomies preserving normal adrenal tissue. Second question, will I have to take steroids after the operation? The vast majority of patients will not have to take steroids after the operation, meaning hydrocortisone. So if you have what's called Conn's syndrome, meaning an aldosterone producing tumor, primary hyperaldosteronism, or if you have a pheochromocytoma, meaning adrenaline producing tumor, those patients do not need to take steroids after. The one type of patient where this can come up is those that have Cushing's syndrome or adrenal Cushing syndrome. Another name for it is subclinical Cushing syndrome or mild autonomous cortisol secretion. They're all the same thing, meaning the tumor is overproducing cortisol. In that scenario, once you remove the tumor, the normal cells have been put to sleep and may need some time to wake up. They're what we call suppressed. And in that interim period, for a short period of time, usually a few weeks to months, you may need some supplementation of steroids. There's some rare exceptions where we have to remove both adrenal glands. This is only 1 or 2 or 3 cases a year in our hands where patients end up on lifelong steroid supplementation. So I just wanted to start with that. So first question we have, can high cortisol levels affect the heart? Before I got diagnosed with Cushing syndrome, I had problems with arrhythmia and also high levels of troponin, but they could not find anything wrong with my heart. Wondering if the cortisol could be the culprit. Yeah, so this is a great question, and it has to do with cardiovascular manifestation of adrenal tumors. So again, just to remind everybody, you can have tumors overproducing cortisol, aldosterone, adrenaline. All those 3 hormones affect the heart in different ways, but all affect the heart. So when it comes to the cortisol, it definitely affects the heart and the vessels to the heart. It sounds like here, if you had elevated troponin levels, that usually is what we call demand ischemia, meaning you have poor blood flow to the heart. So the cortisol in of itself may not be the direct cause in that acute setting, but certainly having adrenal tumors overproducing cortisol over time puts your heart at great risk. And that's also true for pheochromocytomas and aldosterone producing tumors. So with patients with primary hyperaldosteronism, for instance, their risk of heart arrhythmia such as atrial fibrillation and heart attacks is increased about 400% to 1,000%. All right. next questions. I've heard about adrenal vein sampling, AVS, for diagnosing Conn's syndrome. Can you explain how it works and why it's important in determining the need for surgery? Great question, and a topic that is evolving, and my own thinking about adrenal vein sampling has evolved over the last 5 to 10 years. But so first of all, what is it? Adrenal vein sampling is an interventional radiology study where a radiologist put a little catheter through the groin up into the left adrenal vein and the right adrenal vein, and then measure aldosterone levels and then also cortisol levels as a control, but it's only done for aldosterone producing tumors on the left side and the right side, to see if the aldosterone level is a lot higher on one side than the other. And you calculate something called the lateralization index, because if you have an aldosterone producing tumor on, say, the left side, the aldosterone levels in the left adrenal vein will be a lot higher. So in the past, we used to do adrenal vein sampling on all patients with Conn syndrome or primary hyperaldosteronism. What we now know, as we're learning more about this disease, is that it is not required in all cases, because this is, again, remember, this is an invasive study. So invasive studies should only be done if it's absolutely necessary. So in general, and we're actually having a new blog article coming out the next couple of days looking specifically at this. And if you go on adrenal.com, there's numerous articles that talks about adrenal vein sampling in primary hyperaldosteronism specifically. But as a general rule, patients that have an obvious tumor on the scan and obvious disease, they can go straight to surgery and do not need adrenal vein sampling. However, patients that have tumors on both sides, or the CT scan or the MRI show no tumor whatsoever, those patients typically need adrenal vein sampling. But remember, it's all individualized and each patient is different. So that's why it's important to be evaluated by somebody who sees, tens and dozens of patients with this disease every single week. Will removing the adrenal tumor cure my Cushing syndrome, or is there a chance I could still have issues with excess cortisol after surgery? So the short answer is yes, you will be cured of your Cushing syndrome after removal of the tumor. The one little caveat with this is 2/3 of patients with adrenal Cushing syndrome have just one tumor and the other adrenal gland is normal. You remove the tumor, patient is cured. But about 1/3 of patients can have tumors on both sides. So in that scenario, the best operation is removing the tumor on each side, preserving a normal remnant. So the goal is twofold. You remove the tumors, but you preserve enough adrenal tissue that you won't need long-term steroids. All right. I had my left adrenalectomy 30 years ago, and I am now having issues with my right adrenal gland. I have 2 adenomas on my right adrenal, but my doctor says they are shrinking, plus no positive cortisol test. If the low-dose dexamethasone suppression test depressed my cortisol level from 240 millimoles to 200 millimoles. So these are international units, so this is an international patient. Is that normal? What would you suggest I do next? So number one, just to translate this into American units, that suggests that you don't have a complete suppression. So remember, 3 major lab tests to diagnose Cushing. So this patient had the left adrenal tumor removed 30 years ago, and this actually speaks directly to what I was talking to you before. Then now the patient has a tumor on the right side. So the biochemical diagnosis is the same, meaning you need 3 lab tests to test for adrenal Cushing syndrome. Number 1 is the ACTH level. The second one is the low-dose dexamethasone suppression test. And the third one is the DHEA level. The ACTH will be low because the pituitary hormone has a negative feedback. So ACTH will be low. you will have a low-dose dexamethasone suppression test where you fail to suppress. So if that number is 1.8 or higher in the morning after you take that pill at 11 p.m., that's suggestive of Cushing syndrome. And the DHEAS level will typically be less than 100. So I would have to look at all those numbers to be able to tell. But with your history, it's certainly suspicious that you now have a low-dose dexamethasone suppression test that is borderline. But you need to look at all these labs in the context. You need to see the ACTH level, you need to see the low-dose dexamethasone suppression level, and you do need to see the DHEAS level. Then, sometimes in rare instances, the 24-hour urine-free cortisol and the salivary cortisol is helpful too. But those are not very sensitive tests, so they're better for severe Cushing syndrome. They're not very good for mild autonomous cortisol secretion or subclinical Cushing syndrome. If I have Conn's syndrome, what is the likelihood that surgery will completely resolve my high blood pressure? Could I still need medication afterwards? This is a great question. So again, Conn syndrome, too much aldosterone from an aldosterone-producing tumor. And the high aldosterone is very bad for your body because it causes high blood pressure, but then it increases significantly your risk of stroke, kidney failure, atrial fibrillation, heart attacks, right? So when we look at the results after surgery, one of the things we do look at is, how much blood pressure improvement do you have and how many blood pressure medications you come off. But as you can imagine, the more blood pressure medications you're on, the less likely you're going to be that you get off all blood pressure medication. That doesn't mean that the operation didn't work. That doesn't mean that you didn't benefit. It's just that the more blood pressure medications you're on going in, the less likely you're going to be to come off all of them. So every single week I see patients that are on 5, 6 blood pressure medications, and in those patients it's unlikely that they're going to come off all those 5, 6 blood pressure medications. So as a general rule, they usually get off half. So if we can get patient from 6 blood pressure medications down to 2 or 3, that's excellent. That's great results. Conversely, in patients that are on 1 or 2 blood pressure medication, almost all of those come off all the blood pressure medication. So remember, it has to do with how much target organ damage you have when you get going for the operation. So if you have a relatively short period of time where you've had high blood pressure and you're fortunate to have a smart doctor to diagnose you quickly, get you to surgery quickly, the more likely you are to get off all blood pressure medications. But we see patients every single week that have, in retrospect, had this disease for 20, 30 years, and then you have a lot of damage to all your vessels in your body, you have a lot of damage to your kidneys, and if that's the case, you're not going to come off all those 6 blood pressure medications. So it all depends on the individual setting. But again, it's a mistake to think of the improvement after surgery is only related to blood pressure, because we do know that lowering your aldosterone levels in of itself decreases the risk of stroke, heart attacks, kidney failure, and atrial fibrillation. So regardless of the improvement of the blood pressure, which is obviously important, lowering the aldosterone levels in of itself is very beneficial for the health. And that just talks about blood pressure. Then patients have fatigue, often tremor, they have sleep apnea, they have weight gain, they have frequent urination at night, anxiety, depressive symptoms that are all very common in Conn syndrome, and obviously those get better after surgery as well. If both adrenal glands are overproducing hormones, is it safe to have both removed? So this comes back to the question we talked again. So this can happen both with pheochromocytomas, with Conn syndrome, aldosterone-producing tumors, and cortisol-producing tumors, that you have tumors on both sides. And in almost all these cases, you can do partial function-preserving adrenal surgery. Again, two goals. Goal number one, get rid of the tumors. Goal number two, preserve normal adrenal cells. That is almost always possible, regardless if the tumors are overproducing cortisol or aldosterone or adrenaline. So again, yes, the answer is yes. Get rid of the tumors, preserve normal adrenal tissue. What is the best treatment for a pheo? Yeah, so pheochromocytoma are adrenaline-producing tumors, and the short answer is surgery. That's the only curative treatment for a pheochromocytoma. It's true that we sometimes put patients on medications in preparation for surgery to lower their blood pressure, but ultimately there's no other treatment that's curative than surgery, meaning removing the tumor. That makes sense, right? So just remove the tumor. Are there specific signs or symptoms that indicate that pheochromocytoma may be malignant? How do you go about determining this? Yeah, so when it comes, so that we actually technically don't call them anymore malignant pheochromocytoma, we call them metastatic pheochromocytoma, and that might seem like semantics, but the reason for that is we can really never tell for sure that this pheochromocytoma is advanced unless it spreads, and it usually spreads to local lymph nodes or to the liver or to the lungs, but it can spread anywhere. So just looking at the cells, you cannot tell a benign, meaning non-cancerous, from a cancerous or metastatic pheochromocytoma. Unfortunately, there are no specific signs or symptoms to distinguish those that are benign versus those that are potentially cancerous. And the only way to know is either by evaluating the lymph nodes when you do the operation, or if the patient has an imaging study that suggests that the tumor has spread. So if the tumor has spread, again, it usually shows up on either a CT scan or MRI or a PET scan. The most specific PET scan, if you're suspicious about metastatic pheochromocytoma, meaning the pheochromocytoma has spread from the adrenal gland, from the adrenal tumor to other places in the body, is a 18-fluorodopa PET scan, so very specific PET scan. But unfortunately, there's no symptoms and signs that are specific, so you need that imaging study. If you have adrenal cancer, would your cortisol be too high or too low? Yeah, great question. So, of all adrenal cancers, about half of them have adrenal Cushing syndrome, meaning the cortisol level is too high. So, certainly with a big adrenal tumor and very high cortisol level, that heightens the risk of it being an adrenal cancer or an adrenocortical carcinoma. It's very rare that adrenal cancers causes adrenal insufficiency, but in some rare instances that can happen. But the most common scenario would be that the cortisol levels are high. But there are also adrenocortical cancers where the cortisol levels are completely normal, so it's not a perfect test to distinguish between cancerous and non-cancerous adrenal tumors. What is the typical recovery time after surgery, and will I need hormone replacement therapy afterwards, and for how long? And I'll start with the last one. I started out this Facebook Live with talking about this question because it comes up a lot. So in most cases you will not need hormone replacement therapy. But in some cases of patients with adrenal Cushing syndrome, you may need it. The higher your cortisol levels are going in and the longer it's taken you to get diagnosed, the longer you may have to be on it afterwards, but in most cases it's just a question of a few weeks. What's the typical recovery time after adrenal surgery? Yeah, so it depends what adrenal surgery you have. As many of you know, the best operation is what we call the mini back scope adrenalectomy, meaning the 3 small incisions through the back. That's by far the best operation for the vast majority of patients. And in that scenario, the operation that we do, the recovery is pretty quick, meaning that same day you already be able to be up and around. You can take a shower before you leave the next morning. You can take a shower in the hospital. But we tell patients not to do any heavy lifting or heavy exercises, meaning core exercises, so no push-ups, pull-ups, sit-ups, yoga, that sort of thing for 2 weeks. But most people that have an office type job are usually back within a few days to a week. For patients that have a more physical job, like a nurse or a plumber, say, that's crawling into small spaces, may need 2 to 3 weeks or so off. But the recovery from adrenal surgery is pretty quick if it's done the mini-bag scope areolectomy. If you have the laparoscopic through the belly, which is almost never necessary, but unfortunately it's done by most surgeons in the United States. But if you have surgery through the belly, the operation can be, the recovery can be significantly longer, because then the abdominal muscles have to heal afterwards. When the adrenal tumor is removed, can it grow back again? Yeah. So first of all, in almost very, very rare cases, but there are some cases that are important to know about. Number one is in benign tumors, if the tumor cells are spilled, meaning the surgeon doesn't remove the tumor in a careful way, but they violate that capsule, whether it's a pheochromocytoma or even other benign tumors, the cells can spill and implant and grow back, and that's a bad problem, very difficult to deal with. So that's why it's so important to have this operation done by an expert surgeon. Then for adrenal cancer, then there's always a risk of cancer cells that have sort of escaped outside of the adrenal gland, and you can have what's called local recurrence, meaning that the cancer grows back. Again, this is why this type of operations has to be done very, very carefully and with meticulous dissections. All cells are removed, so you have what's called negative margin, so the entire tumor is removed. So again, very rare, but can happen. How do I know if my adrenal tumor is producing hormones and causing my symptoms? Yeah, so again, 3 types of hormones you need to get tested for. You need to get tested for cortisol, you need to get tested for aldosterone, you need to get tested for adrenaline type hormones, what's called catecholamines or metanephrines. The catecholamine and metanephrines are done in plasma, meaning in blood test, or in urine. The aldosterone has to be measured together with the renin, together with the potassium. That's a blood test, straightforward blood test. And the cortisol needs to be screened with a low-dose dexamethasone suppression test, an ACTH level, the pituitary hormone, and the DHEAS, which is another type of steroid hormone. You can go on adrenal.com and we have a whole section that talks about incidentalomas. That's what an adrenal tumor that's found for other reasons. Let's say you go to the ER, you were in a car accident, you have a CT scan, and lo and behold, they find an adrenal tumor. That's what we call an adrenal incidentaloma, meaning it's incidentally found. So all patients with an adrenal incidentaloma needs to be checked for those 3 major hormones. With Cushing syndrome, I've heard that it can be difficult to diagnose. What are the most reliable tests for diagnosing an adrenal tumor that causes Cushing's, and what should I expect during the diagnostic process? Yeah, so first of all, it isn't that difficult to diagnose, but the problem is that in most primary care offices, and even for some medical endocrinologists, they don't see a lot of adrenal tumors. So unless you see patients like this, like we do every single day, tens of patients, if you only if you only do something once a year, it can be difficult, right? If you go play tennis once a year, it's not that easy to do, but if you play tennis every day, it's pretty straightforward, right? So it's the same with diagnosing Cushing syndrome. So it's pretty straightforward. So there's 3 lab tests, the 3 major ones. Again, ACTH, low-dose dexamethasone suppression test, and the DHEAS. The ACTH will be suppressed. The low-dose dexamethasone suppression test will be 1.8 or above, and the DHEAS, the other steroid hormone, will be 100 or below. Those are the 3 major tests. And then there's some ancillary tests, what's called salivary cortisol and 24-hour urine-free cortisol. I'm not a huge fan of those 2 tests unless the patient has very severe disease. And the reason I'm not a huge fan of those tests are that your cortisol level has to be very high for those to be positive. So it's not infrequent where a patient's been told, well, your 24-hour urine-free cortisol was normal, so you can't have adrenal Cushing syndrome. Well, it turns out that 95% of patients that have adrenal Cushing syndrome have normal 24-hour urine-free cortisol. So it's only helpful if you have very, very high cortisol levels, but in most cases it's actually going to come back normal. But we hear that every single week that patients been told by their doctors that they can't have Cushing syndrome because they don't have an elevated 24-hour urine-free cortisol, and that's just not true. It's going to be normal in 95% of the patients. I'm considering traveling from California for my surgery. I've never done anything like this. Is it common for people to come from out of town? How do you handle these types of patients, and how much time would I need to take off work to stay in Tampa? How would I handle follow-up and monitoring at home? Do I need to come back to Tampa? Okay, this is a great question. And so every single day we operate on patients from all over the country and all over the world. We have people flying in from all over, and we do get a lot of patients flying in from California specifically. I think except obviously Florida we get the most patients from Florida, but the other 2 states or 3 states are Georgia, Texas, and California are probably our number 2, 3, 4 states where patients come from. So this is pretty common. So it is very common. So in any given day, actually there are more patients that come from outside Florida than are from Florida with patients. So this is very common. So number 1, so let's say your operation is done on a Tuesday. Most people would fly in Monday, have the operation Tuesday, leave the hospital Wednesday, and then they can travel back on Thursday. That's sort of the minimum time that people take. Some people want to spend a little bit more time in Florida, and obviously they can do that, but that's the minimum time. As I mentioned, most people that have an office job would then be back to work the following week. You have both my cell phone number and the number to the Meredith LaRue for any follow-up. Patients are always welcome to come back for follow-up, but frankly we haven't had a single person that needed to do that because we give them very clear instructions and they only have 3 little small band-aids that need to be removed afterwards. But what we do recommend is the patient has a follow-up appointment with their doctor, usually a primary care doctor or a medical endocrinologist 4 to 6 weeks after. So certainly very common that people fly in for their operation, they stay here. We have a shuttle that takes the patients back and forth to the hotel. We have hotels that work with the patient, so it's pretty streamlined, as anybody who has experienced it will tell you. And we help you with all the follow-up that you need locally when you get back home. What happens if only one adrenal gland is causing the problem and the other is functioning normally? Will removing the problematic gland leave me with enough adrenal function? Yes. So again, so you have 2 adrenal glands. You only need 1/3 to 1/2 of one gland. So certainly if you need surgery on only one adrenal gland, you're going to be just fine. But even if you need surgery on, say, 1.5 adrenal gland, meaning a bilateral operation, you're going to be fine as long as I preserve 1/3 to 1/2 in total. Whether that's 10% plus 40% or 20 plus 30% doesn't really matter, as long as you have a total amount of about 1/3 to 1/2 of a gland. What are the long-term outcomes for patients with adrenal cancer who undergo surgery? Are there any emerging treatments or therapies that might improve my chances of survival? Yes, so adrenal cancer, or another name for it, adrenocortical carcinoma, is a very challenging disease. Unfortunately, first of all, only about 1/3 of patients when they're first diagnosed have disease that's localized to the adrenal gland. The other 2/3 of patients, the cancer has already spread elsewhere, most commonly to the lung and to the liver. And surgery in that scenario up front is not possible. But let's say the adrenal cancer is confined to the adrenal gland, then surgery is the best option and the only curative option. And when we continue to study and do a lot of scientific studies, and we've done a lot of genetic research trying to understand what's the molecular pathology, meaning what are the genetic changes that makes a normal adrenal cell turn into a cancer. And what we do know for adrenal cancer is that it's very heterogeneous. So what that means both genetically and practically is that each patient is very individual. So you have some adrenal cancers that you do surgery and they are cured and they do very well. Unfortunately, that's a minority of patients. The other type of patients, you do the surgery and unfortunately the cancer may come back with liver metastasis or lung metastasis or so forth. So it's a very aggressive cancer, but the only potentially curative treatment is surgery. There certainly are emerging treatments and therapies. One medication that's been used very, very long is mitotane, but it's a tough treatment for patients. There's conventional chemotherapy, but there's more novel, what we call tyrosine kinase inhibitor, which is a more targeted therapy that's being used. And thirdly, there are some clinical trials. So for patients that have adrenal cancer that's spread elsewhere, it's not a bad idea to go on clinicaltrial.gov, which is the NIH, National Cancer Institute's website that tracks all the clinical trials, and this is updated on a very frequent basis. So whenever there is a clinical trial anywhere in the world that where either phase 1, phase 2, phase 3, where they do studies on patients with adrenal cancer, it will show up on that website. So that's a great resource. What do you need for a referral? I would love to be seen at your center. Yeah. So you don't need a referral. It's helpful to get a referral. So if you have a primary care physician and a medical endocrinologist, definitely feel free to have them refer to us. But you can just sign up to become a patient. You just go under adrenal.com and become a patient, and you fill out some initial paperwork, and we track down your labs and CT scan. Our adrenal intake person, Sarah and Millie, will email you and contact you and ask you to send in the records, and then you'll be able to be evaluated by us. All right, so we're getting a few questions in while we're talking. Do you do revision surgery on someone who had an unsuccessful adrenal surgery elsewhere? Yes, we do. Unfortunately, this comes up not too infrequent. The scenario can be sort of what I alluded to previously, where only a portion of the tumor was removed and now it grew back, or some other type of operation where the tumor or the adrenal gland was not completely removed. As you can imagine, anytime you do adrenal surgery and you don't complete the job, so to speak, any subsequent operation has to deal with a lot of scar tissue, and it makes the subsequent operation technically more challenging. But since we're a referral center where often all the most difficult operation is sent to, this is something we see all the time. So we certainly do those kind of operations. I have a myelolipoma on the right. They say they want to remove it at 6 centimeters via a robotic adrenalectomy. Is this what you would recommend? Yeah. Again, I would have to look at the whole picture, and I would have to look at the lab data as well as the individual case. Myelolipomas are fatty tumors of the adrenal gland, and they are not functional, meaning they're not overproducing tumors. But sometimes they may need to be removed, especially if they compress a lot on surrounding structures, or if there's some concern about how it looks on the imaging, as well as if it's growing. When it comes to robotic adrenalectomy, I think I've been pretty clear that that's not the best operation. The best operation is the mini back scope adrenalectomy. The robotic adrenalectomy is done with big robot arms, big incisions through the belly, and the downside with going through the belly is just to get to the adrenal gland, the surgeon has to remove the duodenum, has to remove the colon, has to remove the small bowel, has to remove dissect out the right kidney and move the liver just to get to the adrenal gland. So instead of the operation being 15, 20, 25 minutes, the operation is usually 3-4 hours. And the more dissection you do on those key structures, the greater risk that there's something bad happens. So I would not endorse, I don't recommend robotic adrenalectomy when you have the availability of the mini back scope adrenalectomy, which is the best operation. I'll come back to that one. My surgeon accidentally left behind some adrenal tissue. Is there a way to test the remaining mass with adrenal vein sampling? Okay, so it depends a little bit the context in this case. So number one, I would have to review the whole case, whether you truly had primary hyperaldosteronism or not, and I would have to look at the imaging. The adrenal vein sampling, once you've had previous, so the whole concept with adrenal vein sampling is you compare the aldosterone level on the left side versus the right side, right? But if you've had previous surgery, that vein on one side that was previously operated may have been ligated, meaning cut off. And if that's the case, there's no point of doing the adrenal vein sampling. So if the tumor truly was left behind, but it may have to be removed surgically. But again, it all depends on what it looks on the scan and what the lab tests look and so forth. So last question, are adrenal tumors hereditary? Are there any known mutations? Yes, some adrenal tumors are hereditary or familial. So let's start with pheochromocytoma. So pheochromocytomas, adrenaline producing tumors. So all comers, about 20% of pheochromocytomas has a genetic predisposition, meaning it runs in families. There's 13 different genes where you can have mutations in that cause familial pheochromocytoma. And dependent on what gene is affected, the pheochromocytoma looks slightly different. So the most common ones are what we call MEN2, that's caused by a gene, mutation in a gene called the RET gene, the STHB gene, the VHL, von Hippel-Lindau, and neurofibromatosis type 1. Those are the four most common. But so that's why in pheochromocytomas, in all patients, we recommend genetic testing to check for those 13 genes, because it's important for the patient by themselves, because if you have a pheochromocytoma on one adrenal gland and it's familial, you're more likely to develop a pheochromocytoma on the other side, and you certainly want to know about that. But if you then, most of these genetic types of pheochromocytoma are autosomal dominant. That means if you have it, your children have a 50% risk of having it. And that's important to know, because then patients can be treated and have the tumor removed before it becomes a big problem. So that's pheochromocytomas. Then more, when it comes to aldosterone producing tumors, you can have that run in families, but usually those, when it's autosomal dominant, occurs in a very young age and it's pretty rare. So for the most part, aldosterone producing tumors are not genetic. And adrenal Cushing syndrome falls a little bit in between, meaning it can run in families. It usually affects both sides, if that's the case. So if you have a single adenoma and a completely normal adrenal gland on the other side, it's very rare that would be genetic. But if you have bilateral tumors, it can be genetic. And we and others have been the world leaders in identifying these genes, both when it comes to aldosterone-producing tumors, cortisol-producing tumors, and pheochromocytomas. And in fact, we're continuing that work. So we have a lot of exciting studies that's being planned through our research institute and some of our international collaborations. So we're continuing to push the envelope on this when it comes to identifying genetic causes of adrenal tumors. All right, so thank you very much. We appreciate everybody sending in questions, listening in, and I wish you guys a great evening. Thank you.